So, dear friends, I welcome you to another episode of a Kaho webinar. And this time, the topic is again extremely important, and that is to keep our critical care as safe as possible. And this is based on a very unique project that was undertaken with the help of ISRO, AHPI, and the Indian Society of Critical Care and Kaho. And a kind of guidelines were produced which were called as quality upgradation enabled by space technology, because that was based on the models of the safety paradigms of ISRO. We have today Dr. Y.P. Singh, who is the director and head of the critical care at the Max Super Speciality Hospital in Patparganj, as well as I think in Vaishali. So we'll be looking forward to this illuminating session where we have to see how do we move ahead towards making our critical care safer, which is extremely important in terms of the patient safety, outcomes, and patient satisfaction. So over to you, Dr. Y.P. Singh.
Thank you, sir, for your kind introduction. Good afternoon, everybody. This talk is all about, as sir mentioned, the Quest document. And the Quest document basically means that it's a quality upgradation enabled by the space technology. So I would like to give you some of the insight that how basically this initiative was started. This was started way back in 2016 on 15th of June. The first meeting was being called by Dr. Alex Thomas at that time from the Baptist Hospital, Bangalore. And we from the people from 6 associations, including Indian Society of Critical Care Medicine, Kaho, NABH, AHPI, came together along with Professor J.V. Peter from CBC Vellore and Dr. Menon from the Baptist Hospital. We sat together along with the SEMI, with the Society of Emergency Medicine of India people, office bearers. And there we initiated our discussion regarding the safety of in a 2 area, which is the most critical area, right? Critical care and the emergency. And the 2 scientists were basically appointed by the Indian Space Research Organization for this particular meeting. From there onward, we sat together, we made a certain document, and this document, which I'm going to share in the next 20-25 minutes with you guys, which is having some insight of guidelines, some safety measures, and some of the things which we are already practicing in our hospital right now. But these guidelines are basically being made, keeping in view the level 1, level 2, and level 3, and which can be applied to almost to the entire country for the betterment as a whole to the society. So to moving with forward, this is how the basically health quality says. I think everybody knows that whosoever is listening me, the healthcare quality is the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcome, an assessment of whether something is good enough and whether it is suitable for its purpose. We need to have a 6 domain to fulfill this criteria of the healthcare quality. And to begin with, first it has to be safe, means avoiding harm from the care that is intended to help. In critical care, there is a one dictum. We call it do no harm to the patient if you cannot do good to the patient. Second, it should be effective, means it providing the services based on the scientific knowledge and evidence-based guidelines. Patient-centered, it should be patient-centered, means you are tailor-making all your requirements or the treatment of the patient as per the requirement of that specific patient. Maintaining everything, all parameters, all requirements. Timely, it has to be timely, so you are not having any gap in between. For example, a critically ill patient coming to the casualty trials with the shock. So shock means you have to act in a timely manner to bring back that patient from the brink of the collapse to back to the normalcy, as we all know. So timing is the one factor which is very, very important in critical care, and we have to. So 4th requirement for the safe quality, care is a timely. 5th one is your efficient, avoiding the waste, including the waste of the equipment, supplies, idea, and the energy. Means there should not be any kind of a wastage in view of the duplicacy. Means you are moving efficiently without wasting a time in the right direction for the betterment of the patient. and that should be equitable. So providing the care that does not vary in the quality because of the gender, ethnicity, geographic location, and socio-economic status. There has to be a uniformity irrespective of the caste, creed, and the socio-economic state of the patient. So these are the 6 domains which basically needed there to fulfill the healthcare quality. Now coming to the space technology, why we have chosen ISRO to be included for the safety of all care we are providing in a critical areas like your emergency and in ICU. So ISRO is one of the largest and the most successful space organization in the world, has an immaculate performance record. ISRO develops the critical technologies and strives towards delivering the zero error space systems. Would like to one more things, you can take that way, because during our first meeting with those scientists who was deputed by the ISRO, we discussed with them that what do you mean by the zero error? I'm just, taking their words, just repeating their words. Zero error does not mean zero. There is no absolute zero. It's the only thing what they told us, that what we do in ISRO, that we try to minimize our error. And whenever we found anything to be corrected, we place some SOPs, some guidelines, and some, protocols to be followed by everybody. And hence this document is all about that. To moving into that direction to achieve the zero error. So the quality issue has received much attention in the medical field. Now everybody knows that, because if you are adhering to the SOPs, standard operating procedures, you are adhering to the guidelines, you are adhering to the checklist, you are minimizing the error. When you are working in a system where you are having a different, a department where the team members are working, so bringing in a more of the objectivity in the treatment. So there is a uniformity of the treatment delivered by the different people with the different kind of the competency and the skill in the same manner. So this is basically an objective, and this is how you are basically going to achieve. So independence of preventable errors leading to the patient death is equivalent to the few aeroplane crashes for every 100 flights. So why not incorporate the ISRO best practices into the healthcare, specifically in the area of the emergency and the critical care? And that was basically an objective to incorporate their practices in our day-to-day management of the patient. And the question arises that why they have chosen only the 2 areas, the emergency or the casualty triage. I'll say the emergency medicine and the critical care. Reason: we are dealing with the extremely sick patient in these 2 areas, which significantly drains physiology, which may change dramatically in a few minutes in an environment at risk for the error. Means that you have to remain in a dynamic state. A dynamic state means that you have to tailor-made your treatment as per the requirement of the patient. And the requirement of the patient can change minute to minute, depending on the criticality and the severity of the illness. So you are making the pace with the requirement of the patient. That's basically a meaning. So hence these areas are the dynamic area where you are continuously and constantly you have to keep on a watch, and continuously you have to tailor-made your treatment as per the requirement of the patient. So the nerve center, these 2 areas are the nerve center of the activity where the human errors are the most likely obstacle in the way of ensuring the benefits of advances in the medicine to the fullest advantage of patients. As we all know, because these patients where the results are very low, critically patients where the life and death is only divided by the single, a line, where making an error is going to alter the patient. Hence, you have to be very, very vigilant in these 2 areas. Hence, these 2 areas are basically being selected by the, this group to be look into the human errors which is contributing into the outcome of the patient. So the quality assurance program is basically, we have taken from them, the space system quality assurance program summarizes their quality assurance in 2 practical headings primarily. And these are the 2: paying attention to the details and handling the uncertainties. And what are the prerequisites of the good quality assurance program? And there are the list of the, as you are seeing on your monitor. It should be reasonably simple. It should be locally relevant. It should be easily implementable and should not be resource intense. Because I'm working in a Max Hospital, Max Healthcare. I'm a director and head of department. These are the hospital which provides you almost everything. I'm heading an ICU, which is a level 3B ICU. I'm going to discuss what the level 3B ICU. That's the highest level of the ICU or the critical care which you can provide, or critical care you are providing in any of the setup. So it's not possible that whatever the practices we are having here, the kind of the infrastructure and the manpower we are having, it can be replicated anywhere. So it should be, so I'm coming to, I'm just giving my clearance on that part, that any, guideline which you are making regarding the quality assurance, it should not be resource intense. We can afford, but not all the setups can afford, and we have to look into that aspect. And last is yours should have a tangible outcome which can be measured. Measured means, every time you're finding, you're providing any treatment, you're doing anything, you have to have a certain kind of your measurables which you can measure and can ensure the quality treatment to all the patient and all the time. Moving forward, a quality is in the intensive care, it's basically divided into two broad categories. First is your minimize the events during the transition, and second is your ensuring quality in the intensive care unit. Now coming to the point one, minimizing the event during transition means that it is the prerequisite in all transition care is to ensure that due processes are in place and followed so that the errors are minimized, and events can be minimized by ensuring the predefined transfer criteria checklist. For example, you are taking in a patient, shifting the patient from ward to the ICU. So you are having a predefined, checklist where you are looking into that part, shifting the patient. Hence, you are not leaving any, a point or any, aspect which is necessary for the safety of the patient. And second is the, ensuring the quality in the intensive care unit. So once the patient is in ICU, now there is other processes has to be followed. And on this, on your screen, this is a diagrammatic representation that transition in relation to the intensive care. A patient initially usually coming to the, with my cursor, I'm trying to explain that the patient presenting to the emergency department to our casualty trials. From there, the patient either can go to a ward after the stabilization at the casualty trial, or can go to the ICU, or if some patient needs surgery, they can directly be sent to an operation theater, arranging everything. And from there, after the post-operative, this patient from the OT can go to the ICU, or patient from the casualty trial who needs ICU care can directly, after stabilization, resuscitation and stabilization, can be shifted to the ICU. And from there, they can be stepped down to the HDU and to the step down level 1 ICU. And from there, they can be relocated to the ward, or if some patients who need further care, for example, a traumatic brain injury patient or neurosurgical patients who needs a rehab part. And all those patients where we stuck at one point, and you have to provide them a kind of care where the patient is a vegetative. I'm just taking all those neurosurgical examples to explain my points. So rehabilitation facility or patient can be discharged to the home. So this is a diagrammatic representation how in a seamless manner a patient entering into the hospital through the casualty can go through a stepwise manner and can be discharged home to the rehab centers. Now, the ensuring the quality in the, I should come to the point number 2, how you will ensure that. To ensure that quality domain in ICU, the quality domains used by the ISRO may be applied to the intensive care unit in order to improve quality and work towards the zero error. And how we are going to achieve. They have taken in the following points. Quality in design. What do you mean by the quality in design? A quality in design means that it is the infrastructure and equipment, and second is your human resource or personnel. Now, second is the quality in conformance. Quality in conformance means adherence to the protocol. You have made a certain protocol which has to be adhered by all people to bring in a kind of the objectivity, to bring in a kind of the uniformity, and also eliminating the chance of the error. And third one is your quality in performance, means that whatever you are doing, you are managing your patient, there has to be a certain quality indicators, the kind of the care you are providing in your ICU. And based on that quality indicators, you have to look into that, the kind of the care you are providing to the patient, which will come under the head of the quality and performance. So one is your design, where you are looking after the infrastructure and the equipment. Second is your personal or human resource part, including your medical doctors, nursing, all technical staff. Second part is kind of the conforming means protocol. And third one is your how you are working, what kind of care you are providing, that will be looked after through the indicators, which is outlined by the Indian Society of Critical Care Medicine. Now, here is the same thing which I just enumerated in my previous slide in a diagrammatic representation, that how these domains work. The design, where the expert panel, prelim and the critical design review has been done, and the conformance through the conformance audit protocols and adherence, where are doing the auditing through the quality control department or the quality control people, which is, and the performance looking into the different appraisals or the indicators, quality indicators, how you are the quality, the kind of the care you are providing in your ICU, which has to be, on a regular interval has to be looked into. Based on that, you can go into the RCA, can do your fact finding, and whether we are based on that, on the monthly basis or on fortnightly basis, you are looking into about your care of your patient depending on these criteria. And this is how this particular loop is basically. And based on that, you give your feedback. If something you found during a particular or critical analysis that this is basically a reason where we can look into for the improvement, you do your RCA, give your corrective feedback, and how this basically loop is formed. So parameters of the quality and its interrelationship is basically being shown in this diagram. Now moving forward, how these domains will be reviewed. As I mentioned, design, conformance, and the performance. How you are going to basically assess that whether they are these designs which we are mentioning, where somebody adhering to. Now you can take the preliminary design view where the Indian Society of Critical Care Medicine has very well defined that how much should be in bed space area, how much should be a gap between the two beds, just to prevent the hospital-acquired infection or as an infection control process. Or NABH, National Accreditation Board of the hospital, which is also giving very clear-cut kind of your guidelines. Although the NABH absolutely has not given any guidelines, it is basically the same institution has to make, but we can take the ISCCM guideline, which is available at their site www.isccm.org. Now coming to the critical design review. A critical design review is basically an expert panel, institutions, or you can get it done through the external quality inspection, either through the QCI or through the other agencies. Now, the equipment which is being used in ICU is conforming to the standard, and that standard can be set by the ISRO certification. Now, this is about the design, where we have discussed about the infrastructure, equipment, and about the manpower. Now, coming to the conformance. Conformance is basically a periodic conformance audits. 6 monthly you can do it, which is in this document we have advised, and verified by the non-ICU teams. Non-ICU team means they are not a part of the ICU care, where you are eliminating the element of your bias. Next is your audit feedbacks leading into the corrective actions, and the certification by the external agency like your NABH, ISO, and QCI. QCI stands for the Quality Control of India. The third one is your performance. Performance means it is the KPI, benchmark with the national and international standard, targeting 1, 2, or the 6 sigma, or doing your RCA root cause analysis, leading to the feedback, and then again the corrective actions. This is how basically all these domains are basically summarized in a table form, which I discussed in past previous slides. Now moving forward, the quality in design, the configuration control, that is space allocation for each bed of the surgery space. As I mentioned that the Indian Society of Critical Care Medicine has very clearly mentioned that how much space has to be allocated just to minimize the infection risk when you are providing an ICU care to the patient. And that says that for one non-isolation beds in ICU, there has to be a minimum 15 square meter per bed for non-isolation beds and 20 square meter per bed for isolation beds. What do you mean by the isolation beds? These isolation beds are basically those beds where you are keeping those patients who are hospital-acquired infections. And usually in medical ICU, which we are looking after the adult medical ICUs, we have a negative pressure rooms. Negative pressure room means where you maintain a negative atmospheric pressure of a -2 to -8 atmospheric pressure, the negative pressure in a room. And this room is basically having a meter which is having a display. And on every day, a biomed person comes and just check that pressure, whether negative pressure is being maintained properly or not. And the checklist is basically being maintained. So these isolation beds where you are keeping those patients who are suffering from either those infections, for example, H1N1 patient where you don't want other patients to have an infection. And negative pressure means that infection from inside of the room is not moving outside, means air is moving from outside to the inside. While all those positive pressure rooms are basically being used, bone marrow transplant units, where you are keeping those immunocompromised patients, where the positive pressure are being maintained, where you don't want that patient to have an infection. So air is moving from inside to the outside. So this is the difference between the negative and the positive pressure isolation beds. Now moving forward, what do you mean by the surge space? A surge space is basically a space which is being used for the equipment storage, counseling, classroom, and the administration use. And the surge space is equivalent to the space allocated to the bed. For example, you have allocated the 200 square meter of the space to the beds. You have to have an equal 200 square meter of the space for the surge space for all these activities. All those, uses, equipment uses, counseling, and the classroom, as I mentioned. Now moving forward, how you are basically going to categorize your ICUs, that a designation of the level of the ICU, which I mentioned in my previously. Level 1, I'm moving forward from the down. Level 1 is a step down unit predominantly for the monitoring. I can say that in my hospital, don't take my, just sharing my information. We are starting a VIO system. VIO system means you are having you have converted a one, ward where we are having almost 48 beds into a round the clock 24/7 monitoring of the patients. So simple ward, level 1 kind of, we are using those wards as a level 1 step down kind of a unit where those patients who otherwise don't need ICU care but cannot be kept in an ICU and cannot be kept in a ward also. Those patients can be kept in a level 1 of a ICU. We are doing some kind of the monitoring. We are having 5 parameters in that particular ward which are going to start from 15th of the March 2018. Now level 2 is a high dependency levels where the HDU means high dependency unit, or level 2, where the organ supports but not requiring the invasive mechanical ventilation. All those patients who are basically fit enough to be stepped down from the ICU, or before they are being shifted to the room, they are basically kept for in HDU or high dependency unit or level 2 kind of a place where you can monitor these, or you can keep them in a level 1 where you are monitoring them, and thereafter you are sending the patient to the room. So no patient should directly be shifted from ICU to the room. They have to be at least kept for 24 hours for the observation for the safety of the patient. Now moving forward to the level 3, level 3A is a ICU which is having advanced organ support including ventilator, hemodynamic and renal support. And the level 3B, the difference between the level 3 and level 3B is only the level 3A plus ECMO is making a level 3B ICU. So this is how we basically classify and designate the different ICU depending on their facility or support they are providing to the different critically ill patients. So coming to the monitoring equipment, in my continuation of the same, the provision of the adequate monitoring equipment based on level of the ICUs. So adequate number of the ventilators means 1 per bed for level 3, monitors 1 per bed for level 2 and level 3, infusion pumps and dialysis units. That is basically can be optional in a level 2 ICU. Equipment, minimum standard as laid by the regulatory authorities. Now, some words about the calibration of these instruments. It conforms to the manufacturing standards, for example, the ISRO certified equipments, but also mandatorily calibrated periodically for the maintaining the quality. Because calibration is the first and foremost thing which has to be done on a regular basis, has to be looked after by the biomed, or if these biomed people are not, they have to be done, on a regular interval, and record has to be maintained. And one thing, this document also mentioned that extension of the license for the hospitals may be linked to the satisfactory functioning of these important discipline. Because if you are having a malfunction with your equipment, if your equipments are having some malfunction or some problem, it can basically adds into some of the misery of the patient or some of the adverse outcome or some errors. So they suggested during this meeting in this document that extension of the license for the hospital may be linked to the satisfactory functioning of this important discipline. That's the well-being of the. Now moving forward regarding the management of the manpower, this is still a part of the quality design. Encompass the appropriately trained resource personnel. The quality can be compromised and adverse events can occur if this domain is not appropriately addressed. Obviously, a well-trained, well-skilled team definitely makes a difference in the outcome of the patient in ICU as well as in a casualty trials. A competency-based training and the skill acquisition is recommended. What are the labels of the this human resource or a manpower or a healthcare workers? The 3 levels. One is the factual level, third one is the cognitive level, and second one is the cognitive level, and third one is the procedural skill. Moving to the factual level, factual means they have to have a good knowledge base of the subject. And the cognitive level means they can apply the same, integrate the information, particularly in the complex cases. So utilize the same, knowledge, whatever they are acquiring, they can utilize as per the requirement of the patient in the complex situation. When you have a multiple organ involvement patient who is on a ventilator, who is on a dialysis, who is on a hemodynamic monitoring, where you have to need that kind of the skill and the competence to apply for the management of these patients. Now coming to the procedural skills, when these manpowers are basically being kept, they have to have some competence as for the BLS, ACLS trained. Intubation, they should know intubation. They are basically trained in placing the invasive lines, your central venous line, arterial lines, or the dialysis catheter. Now moving forward, this is here, the recommended competency-based training and the skill acquisition in critical care. The few words I would like to say. As you are seeing here, the CTCCM stands for the Certified certificate critical care medicine course, which is a post MBBS certificate course in a critical care. It's a 2-year course, and after the 2 year, you have to appear for your written examination. That's online, carried by the Prometrics. And once you pass your theory exam, then you have to appear for the practical exam. And when you pass through these 2 barriers, you have been given a certificate of the post MBBS certificate course, the other 2 years course. Second, your IDCCM or Indian Diploma in Critical Care Medicine. That's a post PG course. It has been done for a diploma and for the person who's done a diploma or the degree. For diploma, it's a 2 year, and for the degree, it's a 1 year course. IFCCM stands for Indian Fellowship in Critical Care Medicine, which is considered equivalent to DNB in Critical Care Medicine. All the 3 courses are being basically conducted by Indian College of Critical Care Medicine, which is an academic arm of Indian Society of Critical Care Medicine. I am a faculty. So in my department, in my hospital, these 3 courses are going on since 2011. FNB is a fellowship in a national board. It's basically a course in a critical care by the National Board of Examination, and it's basically it is recommended, keeping in view the shortage of the manpower, skilled manpower, that anesthetist, physician, and pulmonologist who spend 50 to 75% of the time working in intensive care for at least 2 years may be considered as trained intensive care health professionals. For any of the ICU. A junior level, 24-hour junior level cover on the site, and person should be BLS ACLS trained, should be familiar with the basis, of the basic of the mechanical ventilation, and skill can be acquired through the workshops conducted by ISCCM or the other equivalents. Now, moving to the senior consultant, there is a requirement of senior consultant who is trained or skilled enough in managing the difficult airway and the venous access, be familiar with the emergency procedures, have a good communication skills, and he has to be certified through the IDCCM, IFCCM, DM, FNB, or the equivalent. Now, coming to the nursing, that there is a 24-hour junior level cover, or they have to have a team leader in the ICU who is doing the supervisory role. All the nursing staff has to be BLS and ACLS trained, preferable to be critical care nursing certificate. Minimum 1:2 ratio should be maintained on a ventilated patient. We have deliberately taken 1:2. In a tertiary care level of hospitals, the ratio is 1:1 for the ventilated and the hospital infection, acquired patients, and 1:2 for the ventilated patient in a tertiary care level. But for rest of the ICUs, it can be nicely managed with 1:2 ratio for the ventilated patient, 1:3 for non-ventilated patient in ICU. Now, coming to the technical part, respiratory critical care or biomedical technicians, they are desirable, not necessarily in all the hospital and nursing home. They are resource intensive, definitely. And the infrastructure as space equipment, that's adequate spacing between the beds, as I said, just to control your adding into the minimizing the infection risk. Multiple parameter monitors has to be 1 per bed. That's needed for the alert or for the monitoring of these patients. Provision for invasive mechanical ventilation and provision for dialysis is a desirable at the level 2, level 1, level 2, ICUs, and most of the ICUs, not necessarily. At the level 3, definitely, all these, whatever I have mentioned, it has to be. Ratio of the nurse to patient ratio will also change to the level 3, 1:1 and 1:2. Now, moving forward, coming to the safety and security. Recommendation to ensure the security staff proximate to the unit to deal with the difficult situation. A man limit shall strictly be enforced to minimize the risk of the infection. We should also ensure that this would also minimize the disruptive behavior by the relatives of the patient in case of a crisis. Now, coming to the quality of the conformance, which is having the 2 aspects: expecting the unexpected and the paying the attention to the detail. So expecting the unexpected can be looked into the environmental factors or human factors. Environmental factor means you have to have everything. Look into that part. For example, a ventilator malfunction, pump failure, power failure, supply of the oxygen failure. And the human errors means sometimes workers absenteeism. So these are the 2 aspects which is the most important in the overall, managing these critical ill patients, because critical ill patients has to be looked after round the clock 24/7 by 365 days. So these kind of the aspects which can affect the adversely affect the outcome of the patient has to be looked into, and one has to have a provision available for all these. If you are having a ventilator malfunction or the electricity or the oxygen supply, standby kind of arrangements in your respective ICUs. So paying attention to the detail is having the 2. One is the checklist and protocol. As I having the checklist is basically one aspect which minimize the human error, because you are checking all the aspects. So there is a chance of coming to the protocol. Protocol is basically there to bring in the uniformity in the management of the patient. So protocol is basically for the uniformity of the treatment, while checklist is to avoid the human errors. So important to be prepared for the events with the regular mock drills. You have to do your mock drills for all the aspects. If sometimes making a kind of the assumptions that sometimes, for example, my oxygen system, fail, my central oxygen supply fails, then how I'm going to save those patients who are already on a ventilator or on a high concentration oxygen. You have to have that kind of the mock drill and kind of the drill or SOPs in a place to deal with these kind of the exigencies in ICU. Now moving forward, type of the checklist and the protocol. On the left, you are seeing on your screen, it's a transferring checklist, procedure checklist, transfer out checklist, daily care, handover sheets, problem list. And on the right, you are seeing the protocol, the ventilator bundles, procedure, intubation, RTO lines, and CVC inserts bundles. Few words regarding the fast-track phase, as I mentioned, it's for feeding, analgesia, sedation, thromboprophylaxis, head and elevation, ulcer prophylaxis, glycemic control, spontaneous breathing trials, bowel care, indwelling catheters, de-escalation of the antibiotic and other medications. So the fast-track phase is one thing which we check every 12 hourly in our ICU, and it has to be checked because by looking into this, you are almost list I mentioned for for just as a reference, Appendix 1, Transference Checklist, which is having a name of the patient, airway. You are looking at the breathing of the patient, circulation, neurological status, and the equipment when you are shifting the patient from ward to the ICU. There is 3 ways the patient can come to the ICU, just to mention. One thing is that you notice the doctor duty in a ward has noticed that my patient seems to be looking good, but still the patient is maintaining the vitals. That's the step, one way of shifting the patient from ward to the ICU. Now, another ways of bringing these patients is the more, kind of emergencies, that's the RRT and the code blue. RRT and code blue means when the RRT means a rapid response team is when the patient is serious, is not collapsed, is still, has suddenly a collapse, had a low blood pressure, having a breathing difficulty, then the doctor will announce or system will announce the RRT. Within a stipulated time, the team, which is comprising of your intensivist, anesthetist, emergency doctor, cardiologist, has to rush to the place. There is a time frame. There you have to assess the patient. You have to stabilize the patient, bring the patient back to the ICU. Now, code blue is basically when the patient had a cardiac arrest. So again, the same team will rush, will manage, will bring back the patient after resuscitation. So in any system which is considered efficient, system is basically can be assessed by looking into these aspects. Code blue, zero RRT means highly efficient system. Moving forward, these are the appendings for transfer of patient to the HDU or step down to the HDU when the patient is fulfilling all the criteria. Now, very quickly about the bundles, web bundles, CRBSI bundle, COTI bundles. Now, I'm coming to the next point of the protocol adherence, means assessment of non-conformance. You are having certain protocols, you are having certain SOPs. To see that whether the people are adhering to that, it has to be done through the periodic audits to the treatment procedure and the protocols. And it has to be recommended to be done only by the quality control group, not directly involved in the ICU care. So it is the quality team which is looking into this aspect, whether the people are adhering to the protocol in the respective areas or not. And the audits should be passed on as a feedback for the improvement. Most of the system, in the tertiary care level system, they are doing it. And this is one of the requirements. This is the most important aspect, which is adding to the quality care of the patient in ICU or in these critical areas. So quality of performance, next is a quality of performance is having the 2 subdomains, which is the quality indicators and performance analysis, as I said. So we have already discussed the 2 design, conformance and the performance we are coming. So performance can be checked by quality indicators and performance analysis. And quality indicators, as I mentioned here, for any ICU care, where it's moving in the right direction, you have to look into the mortality through the SMR, infection rates, device, coming to your VAP, COTI, CLEPSI, medication errors, or the self-extubation, re-intubation, or bad sore rates. Now coming to the performance analysis is a quality assurance meeting, You are going into the, if you are finding the infection control, infection of a web, cautery or collapse, you have to go into the root cause analysis, take the corrective measures, and then have to rectify the problem. Now, coming to the medication error, feedback and the review, and the self-extubation, reintubation, and the bed sore, and the mortality audits. So these are performance of the analysis. You need to have all these, a kind of a follow, which is being done by the quality control team or the quality, department in collaboration with the intensivist and your admin and the management part. Now, moving forward, quality of the performance, I'm just enumerating the name, not going to the detail. Standardized mortality rate, decubital ulcer, ictogenic pneumothorax, acute renal failure, average length of stay, readmission rate, patient fall rate, adverse event on the error, and the reintubation rate. Reintubation means within 48 hours, a patient get intubated after, being from the ventilator. And the WAP, infection indices means WAP, cautery, CLAPSI, and compliance to the hand hygiene. That's the most important part, and which is the only single contributor which greatly, helps in prevention of the infection control in a critical areas or in a hospital. Now, next, moving forward, the quality assurance meeting, root cause analysis, mortality and morbidity audits, and the feedback and the review. This all basically comes under a quality of performance, where you are checking that whether how the system is working, how the different particular ICU or the team of the people are working and managing their patients. Now, coming to the few words regarding the role of the communication. I've taken this basically in a critical care. We divide the overall management of the patient to the two. One is the treatment, another is the communication. And communication means they all constitute 50-50%. Failing which any of the aspect, you are not going to get your desired results. For example, if you have not communicated properly, you will always remain on the receiving end. Nowadays, the kind of the environment or is going on, the kind of the mistrust is going on, that can only be countered through the good communication and the good documentation. So the communication gap are the one major reason for the difficult situation and errors in the intensive care setup. And there is two types of the communication. Number one, the communication with the patient relatives, and second is the communication during the shift handovers, where you are trying to minimize those errors which can happen. So it has to be detailed, it has to be documented, each and everything. Now, learning from the ISROs, moving forward, learning from the ISROs, what are those? Number one, quality dashboard. What the ISRO has suggested, they suggested that there has to be a quality parameter should be summarized in a quality dashboard that is updated monthly. And a statistical analysis of the trend is also important. It has to be done on a monthly basis and has to be reviewed. And by looking at the quality dashboard, you can assess that in a past month, what was your performance, what is in a present, in a subsequent month, how you are performing. That is looking only at the quality dashboard. So, number two is the innovation or the digitization. Consider the innovation and technology support to reduce the adverse events and the errors. Attempts should be made to minimize the manual interventions in the record keeping or administering the medicine. In my hospital, we are having an EHR or CPRS system, which was there for the last, for 15th of March last year. And it is being introduced gradually in all hubs in a Max Healthcare. So EHR means you are going through a certain, a particular stepwise manner. You can place a filter where you can detect some errors are going on. And this is a one way through the EHR, you can minimize those adverse events or the errors or those kind of human errors, which usually, I'm not saying in all, but definitely do occurs when you are doing the manual kind of your audit, record keeping. So EHR, one thing, this is the one technology where you can take the help to minimize the errors in the overall, in these areas, the critical area or in emergencies. So this is a diagram. This is basically a photograph of a dashboard which is having a different parameters, and through this cursor I'm seeing the mortality, morbidity parameters, process parameters, patient error, and the safety and the infection. So coming to the morbidity, as I said, the SMR you are taking. Now morbidity, looking at the dashboard by single glance, you know exactly that what is going on in my previous month and this month what is going on. So this dashboard is basically has been suggested by, we have taken from the ISRO. Although we are doing in our Max Healthcare, we are doing on a regular basis because we are having our dedicated quality control department. And I hope that the people who are listening on the other parts, they are also having the same, departments working the same. But these documents are basically not made for these, tertiary care centers. They are basically being made for those centers which are having a level 2 ICUs, working at the level 1, or maybe they are moving in that directions, right? So number 3, aspects which we have adopted from the ISRO practice, the establishment of a quality department. Having a quality department is a resource intensive. Although if you are having a quality department, definitely it's a boon, because it's the one thing where you are having a dedicated people looking after, doing your critical analysis, following a watch, giving your suggestion, doing the RCA, and giving the feedback for the corrections. But if those setups which are not basically able to afford these departments, they can outsource. They can take their services on a fortnight basis and on your monthly basis, which can immensely add into the quality management of their process as well as the patient. Now coming the next to the sharing the best practice and the lesson learned. The best practice and lesson learned shared across the hospital through the conferences and the seminars and monthly departmental quality assurance meeting, so that the staff in the department are also aware of these best practices and the discharge their day-to-day activities. So obviously sharing their best practices is always good, and hence all these forums, seminars, and these webinars which is going on, this is also one of an example where we are sharing our knowledge and the skills with the rest of the people. So it's a two-way kind of a traffic where you're sharing the knowledge on either end. Now coming next to the working culture, should offer the best quality service to the patient. All culture barriers existing among the various stakeholders should be removed. Next should be the reference to the standards, benchmarking the services with international standards. Means if you are having some of the infection control indices you have made certain, you have to fix some of the benchmark to begin with, and to try to achieve those benchmark. Once you achieve that, because quality is an ongoing process, it's not a something where at a particular point you reach there you said that I am achieving my quality objectives. Quality is an ongoing process. Once you reach to a particular point, that becomes a zero. Now you have to move forward further to improve upon. So as far as the international standards are concerned, we can take the American, European, the Australian, or the national standard through the National Accreditation Board of the Hospital, NABH is desirable. Now rating in the hospital, as I also mentioned, the increased awareness about the overall figure of the merit of the hospital is generated amongst the patient by evolving the suitable rating. This rating is basically going to immensely help in a way that depending on their quality, depending on their expertise, depending on their management skills, infrastructures, these ratings immensely help in categorizing these hospitals and providing a different kind of a services. To summarize all my talks, this is an overview of overall which I just said in my past 25 to 30 minutes. It's just to take forward is the quality in the design. Again, I'm just for your revision: quality in design, quality in conformance, and quality of the performance. Now coming to the quality in design means it's the parameters for staffing, as I mentioned, your medical, nursing, and the technical staff. Infrastructure means your adequate base spec, as I mentioned. Distance, equipment, multi-parameter monitor as per the requirement, and the training program as a milestone reviews. Now coming to the quality of performance means where we are adhering to your checklist and the protocols. Quality of performance, quality of indicators, your mortality, morbidity, and the other parameters which I discussed, which is adding into your, and through the dashboard. And the practical training, and coming to your practical training means milestones review again, and the certification, and the performance analysis regarding your quality assurance meeting, where you're doing the RCA, mortality, morbidity audits, and feedback and the reviews. This is how you are basically going to add into your quality management of the patient in your ICU and in those critical areas. Yeah, thank you very much for your patient listening. This is all about this quest document. Thank you very much.
Thank you, sir. I would like to thank you for explaining the ISRO guidelines, which can be easily adopted by an institution and will definitely bring about a huge change in the way the critical healthcare is being delivered in our country. So we now take up few questions if the participants have. So the first question from Dr. Shruti is, from where we can get benchmarks for QI?
Your benchmarks, as I mentioned, that they are available, as I mentioned, it is available in a ISCCM site, because most of time this document, when we made this document, we took the benchmarking of the Indian Society of Critical Care Medicine. So you can go to the site of www.isccm.org. There you can find all these benchmarkings regarding the infection control indices, regarding all your design regarding conformance and the performance. So there you can have the basic idea, or you can take up your go to the CDC side where you can have an infection related kind of the benchmarking. But I'm suggesting better you follow your own benchmarking, which is given by the Indian Society of Critical Care Medicine.
So the next question is, how adoptable is the safety measures in rural areas where proper resources are not available?
Yes, I'm just saying that, you know, this document is basically, as I'm working in a tertiary care center, that's a tertiary care level 3B ICU I am managing. So I'm in the beginning, I also mentioned that objective of making this document is not to apply the same practices which I'm following in my hospital at the max. It cannot be applied. It's not possible. Looking at the periphery where you are dealing only with the level 1 ICU. Level 1 ICU means you are doing the monitoring. You are providing a minimal, you know, kind of a respiratory support. For example, you are using a flow generator or a BiPAP, that much. So first and foremost thing which you have to ensure is that the selection of the patient at that particular level. For example, if you are sitting at the rural and the periphery, you are having a certain infrastructure, minimum of the infrastructure, minimum of your monitoring. So based on that, you have to have a selection of the patient, because first and foremost thing is that, as I mentioned, do no harm to the patient and timely shifting of the patient from one area to the another area of the expertise where these facilities or the treatment can be provided. Now coming to the safety part, as I'm saying that safety first and foremost is that, again, depending on the selection of the patient. As an intensivist, I take that way, because if you are selecting your patient judiciously and finding that this patient cannot be managed at that area, where need to be shift that patient, relocate the patient to the higher centers or a nearby, you know, the area where those facilities are available. So safety is the starting from the selection of the patient first. Now, obviously, these all the whatever I have discussed cannot be executed in totality. You know, all at the periphery. So depending on the level 1, level 2, and level 3, you have to take your, as per the, you know, designation of the ICUs, you have to have those facilities available. And when you have these facilities available, you are bringing in the safety kind of measures automatically with that.
So the next question is, how much impact will these implementations have on cost of therapy, looking at it from the customer's perspective?
One thing why you have to understand that, as the law of the land very clearly mentioned, that you cannot differentiate based on the caste, creed, and socio-economical status of the patient. Obviously, quality always costs money, because if you will add into the quality, for example, if you wish to have an infection control measures, first and foremost thing that if you are making an ICU setup in your place, whether it's a level 1, level 2, level 3, and you are adhering to your those prescribed, you know, parameters, for example, your bed space, surge space, equipment requirement, definitely it is going to add into the cost of the therapy. Number one. Number two part, that as the law of the land very clearly says, and as all these services are coming in a indemnity, you know, area where we are dealing with the medical legal aspect of all these, you know, in a day in and out. So coming back to your part, that as the law of the land, they are least concerned about your cost part as far as when the legalities are concerned. Definitely quality always costs money. I endorse that, and I'm taking your words and also saying the same thing. Definitely, if you're adding into the quality, it is going to add into the cost of the treatment. Definitely.
Next is, how much impact will these implementations? What is an ideal ICU setting, sir? Closed, semi-open, or open?
I will suggest, depending on the expertise, depending on the human resource and the infrastructure available, it basically, so open ICUs basically is suitable for those areas where the people are doing the open, you know, a freelance practice. For example, the level 1 at the periphery, when the nursing home setups are there, level 1 and level 2 setups are there, where you don't have those expertise and those manpower available, trained manpower available, which can provide these services around the clock 24/7. There you is an open kind of a ICU is definitely they are working in those areas. Otherwise, it is a semi-closed, and the closed ICU is considered to be the good ICUs where you are having a round-the-clock trained personnel sitting there looking after the patient and providing the care to the patient. They have a direct impact on the outcome of the patient. So closed and semi-closed ICU are considered to be the best. Open ICU are not considered because there is too many of the stakeholders which take their decision, and there is sometimes that adversely affect the outcome of the patient.
The next one is, which score do you feel to be more appropriate to measure the criticality of the patient?
I'm sorry, can you repeat? Can you come again?
So which score do you feel to be more appropriate to measure the criticality of the patient?
Which score means Apache 2 score we use in our ICU. On arrival of the patient in the first 24 hours, we use the Apache 2 score. And based on the Apache 2 score, you can get this, application on online. And based on the Apache 2 score in the first 24 hours, I'm talking of the, the worst vitals you have to take in the first 24 hours to calculate your Apache 2. And based on the Apache 2 scoring system, you have to predict your predictable mortality rate. And based on that, you can counsel your patient well in advance regarding the outcome of the patient and take the corrective measures accordingly.
So the next one is, which clinical audits can be conducted in level 3 ICU to ensure expected outcome?
The clinical audits, definitely it's on a day-to-day basis how we are working. I can share with that. I think and give you some of the insights that in my ICU regarding we considered these are the indicator of the good quality, ICU care. Number one is your average length of stay. Number two, infection control indices. Number three, mortality. Number four, your readmission to the ICU within 48 hours, reintubation within 48 hours. These are some of the measures we, track every month, every day, every month, and it is basically discussed every month in our local meeting. They are tracked by quality control. They are tracked by infection control team on that basis. And on that basis, with the supervision of the quality control team, with the help of the admin and the medical admin and the management, we do our introspection, we find out the reason, and we take the corrective measures. So it is the quality control team along with the other, committee members, because we are having a different committees to look after the other aspects. A mortality clinic, for example, a mortality clinics or a mortality meeting, all the departments are basically has to do their mortality meetings every month, once in a month. And based on that, there is a monthly morbidity and mortality clinic. They look into that part, that whether these patients in our hospital on a particular department, we had a unexpected category 2 or category 3 kind of a mortality. Based on that, we go for the peer review as well as for your REG, risk assessment analysis, we do on that. So giving you some of the insight onto that regarding the mortality, that we categorize the mortality into a 3 category. Category 1 mortality means that those subset of patients who are moribund, who are sick, terminally ill, they comes in a category 1. If these patients are coming to the hospital, primarily these patients are onco patients, which are having a metastasis, having a multiple organ involvement, category 1 patients. Category 2 patients further divided into a 2, expected and unexpected, 2A and 2B. 2A means a patient was sick enough at the time of the admission, and that patient in due course of time has deteriorated and died. They comes under 2A. That patient could have been survived, could have been died. Maybe the Apache score could have been in the higher range, predictable mortality in the range of 70 to 80. These patients comes under category 2A, expected. Category 2B means unexpected. A patient at the time of admission was not sick enough to die, and the patient died during the treatment, comes under the category 2B, unexpected. Here, we are going to sit together. We are going to do a critical analysis. We are going to do the peer review. And for the peer review, the other team from the other hospital will come, and they will go into all the complete detail along with your quality control and with the medical admin. And based on that, if there is a certain of the gap, we do the analysis and we execute that so that things should not be repeated again in the next. Now coming to the category 3 means unexpected death. A patient came for the elective surgery, died. A patient came, for a medical patient, came at the time of admission, was not sick enough, neither at the time of admission, nor during the treatment, and died. There might be some of the gap during the treatment. Here we do the peer as well as the REG. So this is how we basically move, and definitely it is a quality control department which looks into all the aspect. And here in to sum up, giving the insight into how the Max Healthcare work, it is basically a 2 verticals. We have the clinical and non-clinical. Clinical is basically headed by clinical directorate at the Max Healthcare level on the all 14 hospital. And the hospital level, we are having a medical advisor, which is a doctor looking into all the clinical aspect and all the day in and out, and which is considered to be the head of all committees, whether it's the infection control, whether it's your performance improvement, whether it's your OTIC user, whether it's your mortality. So probably, hopefully, I'm able to give the answer of your queries. Am I?
Yes, sir. There is one more question. Where can they get the standard benchmark for quality indicators?
As I mentioned, it's again the same, you can get it through the Indian Society of Critical Care Medicine site, where they have mentioned all these benchmarks regarding these quality indicators regarding their performance and the benchmarking. So it's Indian Society of Critical Care Medicine. Again, I'm repeating the same. The site is the www.isccm.org. There you can go and get these benchmarking, which in the Indian context we have made. Connection lost हो गया क्या? It's lost. No. Hello. Am I audible? So this discussion comes to an end. This webinar comes to an end. Thank you very much again for the patient listening and sharing my views. Can you connect to the Dr. Vijay? Can you stop? Connection. I think we have lost a connection.
So we had lost connection now.
Yeah, not a problem. I am still online. Am I audible?
Yes, sir.
So I think if we don't have any of a query, we can stop here.
Hello. ठीक है sir. Okay, sir.
If we have no more query, we can stop here.
Yes, sir. We can close the session now. And those who have queries, they can post it at kaho.in@gmail.com.
Thank you. Thank you very much.
Okay, sir. Thank you so much for taking out your time and explaining the ISRO guidelines in CCU. Thank you.